Very good morning and warm welcome to all the participants. On behalf of the Department of Oral Pathology, SR Government College, Ramapuram, we welcome you all to the webinar titled Reporting of Oral Cancer with an update on the new AJCC guidelines. Before we start with the webinar, we would like to show you a glimpse of our department. Now, I request our Vice Principal, Professor and Head of the Department, Dr. K. Rajkumar sir, to give the welcome address. Over to you, sir.
Hi, everyone. On behalf of the Department of Oral Pathology at SRM Dental College, Ramapuram, I extend a warm welcome to everyone on this bright Saturday morning for today's webinar. A big thanks and a special welcome to our distinguished speaker, Dr. Anand Ramanathan, for having accepted our invitation to conduct today's webinar. Before we start the proceedings, I'd like to say a few words about today's topic. Even though we oral pathologists play an important role in diagnosing various diseases of the oral cavity, the histopathological assessment of the formalin-fixed tissue and the surgical resected specimen cases of squamous cell carcinoma remains a cornerstone in our profession. Here, I would like to emphasize our role in reporting cases of squamous cell carcinoma. Apart from confirming the diagnosis of squamous cell carcinoma histologically, we take the trouble of looking into the deeper section, looking for reoriented sections just to confirm the histological staging of squamous cell carcinoma as well differentiated, moderately differentiated, and poorly differentiated. Why should we do that? Well, we are all aware the importance of this histopathological staging. As we all know, it plays an important role in the prognosis and deciding the treatment outcome. While that is more important, does our role stop here? No. Let's see why. The management of squamous cell carcinoma is based on surgical resection with or without adjuvant treatment like radiotherapy or chemotherapy. Indications for this adjuvant treatment is influenced by various factors. One important factor is the histopathological staging, which I just mentioned. There are other factors as well. The depth of invasion, the involvement of bone, the vascular or neural involvement, the status of the margin, the status of the lymph node involvement, and in case if the lymph node is involved, whether there is any extracapsular spread, or whether there is any extra nodal extension, or to say in a nutshell, the TNM staging. In this context, the American Joint Committee on Cancer, AJCC, first released the TNM staging manual in the year 1977. Since then, a lot of corrections have been added, and the 8th manual of AJCC was released in 2016 to be implemented from 2017 onwards. What does this got to say? It has got two important suggestions as far as oral squamous cell carcinoma is concerned. One, incorporation of the tumor's depth of invasion, TOI, in the T stage, and incorporation of extracapsular spread, ECS, and extranodal extension, ENE, in stage N. In case we want to incorporate these suggestions successfully, we need to have a good communication with the surgeon. We need to have a proper orientation of the specimen. We have to focus on grossing of the specimen, and we have to do a liberal viewing of the deeper section and recruitment of fresh samples as and when the case is required. Even though the guidelines for doing this are there in the manual, oral pathologists frequently encounter ambiguous conditions, environments, which leads to inter-observer and intra-observer variability. So it is very important to overcome these difficulties and then create a consistent interpretation. I repeat the word consistent interpretation, because this plays a very important role and has got a direct impact on the patient's prognosis and the treatment outcome. Today, our guest speaker, Dr. Anand Ramanathan, is going to talk to us about how to overcome these difficulties while reporting cases of squamous cell carcinoma using the AJCC guidelines. I now request Dr. Dinesh Kumar to introduce the guest speaker to our audience.
Thank you, sir. Before I introduce the speaker, a piece of information for the audience here. So please post your questions in the chat box, which is enabled. So you can post your questions. And for the feedback form, the feedback forms will be posted at the end of the session. Please hold on till the end of the session. The feedback forms will be posted in the chat box, so you can fill up the feedback form for your certificates. And now coming on to the speaker, Dr. Anand. Welcome, Dr. Anand. Dr. Anand Ramanathan is a faculty in the Department of Oral and Maxillofacial Clinical Sciences at Faculty of Dentistry, University of Malaya. An oral pathologist by training, he has been involved in academics and research for the past 9 years. He holds a BDS degree and a master's MDS in oral and maxillofacial pathology from India. An ardent researcher, he has about 50 papers in indexed international peer-reviewed journals to his credit. He is involved in numerous research projects and has supervised PhD, master's, and graduate research students. He has also presented numerous papers in international scientific conferences. His areas of research include oral cancer, oral potentially malignant disorders, oral pathology, oral medicine, immunohistochemistry, natural products, and drug toxicity studies. Dr. Anand has experience in teaching both graduate and postgraduate students in oral pathology and oral medicine. He specializes in case-based learning and is an active member of the Oral Cancer Research and Coordinating Center at Faculty of Dentistry, University of Malaya, and trains and calibrates young dentists and specialists in early detection of oral cancer. So welcome, Dr. Anand, and now it's over to you for you to take over the session.
Thank you, Dr. Dinesh. Thanks for the kind words of introduction. Let me share my slides first. Are you able to see my slides?
Yes, Dr. Anand. Yeah, it's visible. You can go ahead, and your audio is also good. You can go ahead.
Thank you.
And I request all the attendees to put yourself on mute, and the session goes on. Thank you. So you can continue, Dr. Anand.
Thank you. I'd like to first thank SRM Dental College, the chairman, Dr. Shivakumar, Dean, Dr. Ravi, and Vice Principal, Dr. Rajkumar, for inviting me for this webinar. And I would like to thank Dr. Dinesh, my friend, who came up with this request. I'd also like to thank my dean, Professor Dr. Sabari Musa, and my head of the department, Associate Professor Dr. Zureza Mohammad Zaini, for giving me the green signal for this webinar. This is where I work, and this is the old block of my faculty, and this is the new block. This is where we have our oral pathology lab. I'm sitting inside there giving you this lecture. And on the 7th floor here, we have the Oral Cancer Research and Coordinating Center. And this is also the PG Clinic block. So to start with the conflict of interest, and let me go on. This is what people think about pathologists in UK. So guess what they will think about oral pathologists? They wouldn't have even heard about us. So, but my work under the microscope is very colorful, and I see a lot of colors as well as patterns. If I need more colors, I put more colors. Sometimes I put brown color to give me more information. Sometimes it can be multicolored. These are my work. Coming to today's topic, oral cancer reporting. I'll be talking mainly on the tumor. Usually we report the tumor and the microenvironment. I'll be touching the microenvironment part, but mainly talking on the tumor. The topics which I will not discuss in this presentation are these. Okay. What does the surgeon want from you from your surgical specimen report? If only the surgeon had a crystal ball and he could see in the crystal ball what is the survival rate of the patient, what is the recurrence, is this patient going to have a recurrence or not, or if the patient is going to have a lymph node metastasis or distant metastasis, that would be the greatest thing that surgeon would love to have, and the greatest benefit the patient will have, so that he can plan what next to do for this patient. It can be in treatment planning or the quality of life of the patient. It doesn't matter which, but both are important. So this crystal ball, that is what the oral pathologist is going to give. We are going to put informations in this.
Dr. Anand, I'm sorry to interrupt at this time. I think your voice is a little bit feeble. Can you be a little bit louder, please?
Okay.
Yeah. Sorry to interrupt. Go ahead.
Okay. Can you hear me now?
Yeah, it's fine. Go ahead.
Okay. So if we can put things in this crystal ball and tell him this is what is going to happen to the patient, he will be it will be very, very helpful for him. And that is where the communication between the oral pathologist and the oral surgeon is very important. Like my kids are playing here, trying to communicate with each other, and it shouldn't be a one-way communication, it should be a two-way communication there. Okay, the first thing the surgeon is going to see in your report is the margin status, the status of the resection margin. That is what he's very, very keen to look at, because he wants to know whether he has removed the whole tumor or not. So coming here, we have different margins which we have to report. We have the mucosal margin which we have to report, the deep margin, as well as the bony margin if the surgeon has cut the mandible or maxilla and given you. Okay, this is a schematic presentation where you can see that the surgeon is cut through the tumor, and this is a positive margin. It's going to be where it's going to be involved, and this is a negative margin because the margin is very far away from the tumor. But how far is negative, and how do we grade the margin? Okay, let's come to that later. But if the surgeon is going to send you a specimen when the patient is on the table of the operation theatre, then he might be asking you to send you a fresh specimen where you need to snap freeze it, and then you need to section it, and then do one rapid H&E and report whether you see the tumor or not, whether the margin is positive or not. So if it is not positive, good enough, but if it is positive, you're going to tell the surgeon and he's going to revise the margin. So the clear margins are the tumor is about more than 5 millimeters away from the margin. The close margin is between 1 and 5 millimeters. If it is, we'll report it as involved margin if it is less than 1 millimeter. So this is very critical for the surgeon, because he is going to based on this, he is going to do his next step of treatment. Okay, what about the dysplasia at the margin? Okay, what about mild dysplasia? That's questionable. So one paper says that the moderate dysplasia and severe dysplasia are supposed to be put as positive. Let's come to that a little later. This is going to be the surgeon's reaction. If you're going to give a clear margin, he's going to be very happy. If it's close margin, he's a little concerned. If it's involved margin, he's very angry. He might show that anger to you as an oral pathologist sometimes. And if he does that, the only one thing I do is I'll call the surgeon, sit with me and see these slides and explain to him where the tumor is and where the margin is. Sometimes it is better if you call the surgeon when you are doing the crossing, because they would know the exact way they have cut, and they will be able to help you, tell you where the margins are, what margins are, and so on. Okay, and for the surgeon, it is very easy for them to do the mucosal margins, but the deep margin is always a big problem for them. So that is where they have a bit of a problem, and usually there will be a problem between the oral surgeon and the pathologist when reporting the deep margin. Okay, coming to the dysplasia in the surgical margin, this paper says that it is not an independent risk factor for disease-free survival or overall survival. So I'll have to take this paper as a pinch of salt, because there are other papers contradicting this. Okay, so why there is a contradiction between the surgeon and the pathologist when it comes to the margin? It might be because of the tissue shrinkage in the margin area. If you see T1 and T2 tumors, they shrink more than T3 and T4 tumors. And the site also plays an important role. Buccal mucosa tumors tend to, and mandibular alveolar tumors tend to shrink more than the maxilla and tongue. When it comes to the cutting method also, the conventional scalpel will shrink more than cutting diathermy. But cutting diathermy have to be careful, because that's going to give the pathologist a nightmare, because this is how the tissue is going to be friable, and it's very difficult for the pathologist to read such a tissue. Okay, going on to the differentiation. Yes, we've all been taught how to differentiate the squamous cell carcinoma, a well differentiated squamous cell carcinoma here, a moderately differentiated one, and a poorly differentiated one. So if you are going to give this piece of information to the surgeon, he's going to say, so what? Okay. The evidence at present is currently there is lack of consensus whether the grading based on the tumor differentiation helps in predicting the prognosis of the tumor. Previous studies have always been telling that well differentiated has a good prognosis, whereas the poorly differentiated has a bad prognosis, and the moderately differentiated has an intermediate prognosis. The problem is not between the well differentiated and the poorly differentiated. The problem is at the moderately differentiated, because nearly 60% of our cases we will be reporting as moderately differentiated, and there is the discrimination. It is not able to discriminate properly. So that because of that, there's lack of consensus here. Going to the cellular and nuclear pleomorphism. Okay, you are reporting cellular and nuclear pleomorphism. It can be mild, moderate, or severe one. Here you can see the nuclear pleomorphism much better. But for the surgeon, what are you talking about? It doesn't give him much of information. Mitosis is another one where we are going to say this many of mitosis in 10 high power field. The place where we have to do this mitotic count is at the invasive front, okay, and see at the invasive front or the deepest part of the tumor, and look at 10 high power field and give the number of mitosis there. Okay, the surgeon might say, oh, I see, okay. The evidence here is it is an independent prognostic factor. Mitotic index has been an independent prognostic factor, and it has been reported in many risk models too. Coming to the stage of invasion, okay, micro invasion and superficial invasion, we'll have to say whether the tumor is at the junction between the epithelium and the connective tissue, subepithelially, that is microinvasion. If it goes a bit beyond at the lamina propria area, that will be superficial invasion. And we'll also be giving whether there is muscular invasion. Okay, and here you can see the tumor actually invading through the muscle. Okay, what does this say to the surgeon? Oh, it must be very deep. That's the maximum it can say. And at present, there is no evidence in the literature about the sarcolemmal spread and the prognosis of this finding. So we need research for this. Coming to the bone invasion, there are two types of bone invasion. You have the infiltrative invasion as well as the erosive invasion. Erosive invasion is that you have the tumor islands, which are large islands, trying to push into the connective bone, as they are present at the connective tissue and trying to push into the bone. Whereas this is an infiltrative type of bone invasion, where you can see that the smaller islands are infiltrated between the bone. So we need to report these two, whether it is erosive or infiltrative. I will tell you the significance of these two later. So what does the surgeon think of? Okay, but what about the bone margin? He's more concerned about the margin. Has he cleared the margin or not? He knows that if it has gone into the bone, it is the prognosis is bad, but then he is more concerned about the bone margin, whether he's cleared the bone margin or not. Okay, going into the pattern of invasion, there are about 4 to 5 types of pattern of invasion. The first type is cohesive, where you have the tumor invading into the connective tissue as large pushing borders of cells. Okay, the type 2 cohesive. Going on to type 1, it is called cohesive pattern of invasion, and it is a non-aggressive pattern of invasion. Going on to type 2 pattern of invasion, again it is cohesive and it is non-aggressive, where you have the tumor actually going in broad islands or narrow islands into the connective tissue. Okay. The third pattern of invasion is non-cohesive pattern of invasion, or it is also comes under the non-aggressive pattern of invasion, where you have small islands which are greater than 15 cells. So you have these islands which are greater than 15 cells. The fourth one is the most aggressive pattern of invasion. It comes under the non-cohesive pattern of invasion, where you can see either they are invading in individual cells or in small group of islands less than 15 cells. Okay. Professor Margaret's group actually added the fifth pattern of invasion, which is called the aggressive pattern of invasion, where you can see satellite islands of cells which are away about 1 millimeter away from the main tumor. So if you're going to see satellite tumors away from the main tumor, about more than 1 millimeter, then you call that as type 5 pattern of invasion. Okay, here you can see that there is a pattern of invasion. You have the island of cells which are satellite islands of cells which are away from the main tumor about more than 1 millimeter. The pattern of type 5 pattern of invasion also can involve a nerve, or it can involve a blood vessel. So here you can see that this is a main tumor, and you have the island of cell which is invading around the nerve. And that could be also you can have a pattern of invasion type 5 with an emboli in a blood vessel away from the main tumor more than 1 millimeters. Then you call that as pattern of invasion. Here the surgeon is going to get my attention, and he will say, I'm listening. So what is the evidence we have for reporting this pattern of invasion? Yes, pattern of invasion is said to be an independent prognostic factor in multivariate analysis in oral squamous cell carcinoma. And this study also validates the risk model. It validates the worst pattern of invasion. It says the type 4 pattern of invasion or type 5 pattern of invasion has more loco-regional recurrence, whereas when it comes to disease-free survival, the type 5 has is a significant factor. Going on to the tumor budding. Tumor buds are single cells or less than 5 cells at the invasive front. And how you evaluate this tumor budding is you'd see under 20x magnification and count the number of tumor buds which are either single cells or less than 5 cells. Okay, so here you can see the tumor buds and you count the tumor buds, and if they are less than 5, it tends to be low activity. If they are more than 5, it tends to be higher activity, and the surgeon's reaction is going to be, oh, I see, that's something new. Okay, coming to the tumor bud, Professor Livio's group have done a lot of work on the tumor budding, and they say that tumor budding is associated with poor prognosis of the patient, and the hazard ratio is about 2%, two-folds. And they have also done a meta-analysis of tumor budding in oral squamous cell carcinoma, and they say that the tumor buds do affect the lymph node metastasis, disease-free survival, as well as the overall survival of this patient. Coming to the next factor, the lymphovascular invasion. Here you can see that the tumor is invaded into the blood vessel. You need not worry about whether it is lymph vessel or blood vessel. You don't need to differentiate between them, but if you see this, you need to report this as lymphovascular invasion. And if you have reported that, then your surgeon is going to say, oh no, he's going to be very concerned because lymphovascular invasion can cause more lymph node metastasis. The evidence says that there is a possibility of more lymph node metastasis if you report lymphovascular invasion. And there are not many risk models which actually do talk about lymphovascular invasion. It's only the Martinez model which gives credit to the intravascular or lymphovascular invasion. And they do take this vascular invasion as one of the criteria in their model. Coming to the perineural invasion, okay, there's a lot of debate between in perineural invasion. The criteria for the perineural invasion is pretty debatable. Some say that a tumor bud either in the epineurium, perineurium, or endoneurium of the nerve is considered as perineural invasion. Others want the cuffing of the tumor around the nerve, and they put it as 33% of the nerve should be cuffed with the tumor. And if you are going to give this perineural invasion in your report, again the surgeon has a big headache, because perineural invasion has shown to be important for locoregional recurrence, as well as lymph node metastasis and disease-free survival, as well as the overall survival tends to be poor if you have perineural invasion. Coming to the tumor thickness, okay, how we measure the tumor thickness, you draw a line at the basement membrane zone, and then you actually draw the then a perpendicular line is placed from the depth of invasion to the surface. So that will be the thickness as such. The actual thickness is going to be here, but then the reconstructed thickness is going to be this. But then the problem is, if you look at the actual thickness of the, if you take the actual thickness of the tumor, for proliferative tumor, it will overestimate the prognostic value, whereas for the endophytic tumor, it will underestimate the value. So usually people don't talk about tumor thickness, they go on to depth of invasion. How do you do depth of invasion? Again, you draw a line from the basement membrane of the adjacent epithelium, okay, and then do a plumb line called perpendicular line from the basement membrane to the depth of invasion. So that would be your depth of invasion, deepest point of the tumor, that would be your depth of invasion. So depth of invasion has a lot of significance because depth of invasion is prognostically significant for locoregional recurrence, as well as the overall and disease-free survival are poor when the depth of invasion actually increases. With that, we come to the AJCC. This one, you have the pathological tumor size, the new AJCC. Let's see the difference between the 7th edition and the 8th edition. In the 7th edition, you have T0, which is no evidence of tumor, but in the 8th edition, they have removed that. And T1, the difference is that they have added the depth of invasion, which should be less or equal to 5 millimeters. In the T2, you can have a tumor 2 centimeters or less in greatest dimension, like your T1, but the depth of invasion is increased. That is more than 5 millimeters to less than or equal to 10 millimeters. So that is an addition in the 8th edition. And you have the tumor more than 2 centimeters, but not more than 4 centimeters in greatest dimension. But there the depth of invasion should be less than or equal to 10 millimeters. So they have added this in AJCC 8. In the T3, they have added on to the depth of invasion, which is greater than 10 millimeters. So it can be either T1 or T2 tumor as in 7th edition. The greatest dimension can be T1 or T2, but if the depth of invasion is more than 10 millimeters, then it falls under T3. So you automatically will be upstaging T1 and T2 from 7th edition to T3 here, if the depth of invasion is greater than 10 millimeters. For T4A, for lip, there is no changes. For oral cavity, they have taken out extrinsic muscles of the tongue because it is very difficult to see under the histopathology whether it's going to be extrinsic muscles of the tongue or not. So they have taken out the extrinsic muscles of the tongue. So that's about the depth of invasion, PT. Coming to the pathological nodal status. Okay, you have to look into and say whether there is tumor present in the node or not. And this I'll be touching a little bit of grossing here because you can do you might get the nodes actually fixed on a paper with the level of the nodes, or you might get the nodes in separate bottles. Whichever way you can, the surgeon sends, it's both are acceptable, but only that if it's sent by bottles or by fixing onto a paper, it is very much necessary that the surgeon actually puts in the level of the nodes. Okay, and going to talk about a little bit of the micrometastasis here. The micrometastasis is a tumor which is less than 2 millimeters in size in the node. If it is more than 2 millimeters in size, it is just conventional metastasis. And in this lymph node, you can see that the lymph node metastasis is without the extrascapular spread. But if you are not sure, you need to do a lot more serial sections and see whether there is an extrascapular spread or not. And when you're grossing, if you're going to cherry pick the nodes, then you have to be very careful that you actually have a little bit of fat tissue around the tissue around the lymph node. If not, you will miss out the extranodal extension or extrascapular extension, which is required for the reporting of AJCC 8, AJCC 8. So you need to be very careful when you're doing the grossing. Take a little bit more of the tissue around the node. Coming to the lymph node metastasis with an extrascapular spread, and here you can see very clearly that the tumor is actually gone beyond the capsule of the lymph node. But at times it is challenging to see whether it is gone beyond or not, and when in doubt, it is better to actually not give as extrascapular spread, And when in doubt, you will have to go for serial sections. Even after the serial sections you are in doubt, then it's better not to give as extrascapular spread if you're not very confirmed. Okay, the next one is the level of lymph node metastasis. It's not enough to say whether the lymph node metastasis with extrascapular spread or without extrascapular spread. You need to say the number of lymph nodes as it is necessary for the AJCC 8, but also the level of the extrascapular spread or the level of the lymph node involvement is very, very important for the surgeon, because if you're going to say that level 1 is involved, then the surgeon will actually communicate with the oncologist and saying that the level 1 is involved, and the oncologist will actually, they'll go for shining, they'll be doing a radiotherapy for this patient, and that radiotherapy, they need to know where they need to give more of the radiation and where to give less of the radiation. So the level of the lymph node metastasis is very important for the oncologist and the oral surgeon, and if you're giving that, it's a thumbs up from the surgeon. He'll be very happy. He will know exactly where he has to shine for this patient and where he need not shine. And extrascapular spread is going to cause poorer survival. Okay, this is the AJCC 7th and 8th edition comparison. Here, N1, they have added on without extranodal extension or extrascapular spread. They are one and the same. In N2A, again, it's an N1 node or a contralateral lymph node, 3 centimeters or smaller with extranodal extension. So this is an addition in AJCC 8th edition. So this is something you have to keep in mind. In N2A itself, you have an extranodal extension, but for the small lymph nodes, it can be single ipsilateral or a single contralateral lymph node of 3 centimeters or smaller with an extranodal extension. Or it can be same as the N2A of 7th edition without an extranodal extension. So they can be lymph nodes which are 3 centimeters to 6 centimeters, not more than 6 centimeters without extranodal extension here. So you have two criteria in N2A, so be careful with that. In N2B is again without, they have just added without ENE. N2C is again without ENE, so you have no issues there, but they have added N3A and N3B. In N3A, you have a metastasis in the lymph node more than 6 centimeters in greatest dimension without extranodal extension. That is almost the same as N3 of 7th edition, but they have added, it can be lymph nodes more than 3 centimeters in greatest dimension with extranodal extension, or multiple ipsilateral, contralateral or bilateral lymph nodes, any with extranodal extension. This is a major addition in the 8th edition. So if you need to report the extranodal extension, you need some tissue around your nodes. So when you are cherry picking, you have to be very careful. You need to take a little bit more tissue than the node itself. And if you are not cherry picking, and if you are going to cut all the tissue at 5 millimeters distance, then it shouldn't be a problem for you. You will have the tissue around the nodes to actually evaluate. Coming to the pathological metastasis, there is no change in between 7th and 8th edition. It holds good. M0 is absent, M1 is present. So if you have given this to the surgeon, then it makes sense for him and he will thank you. Okay, let's go on to see a little bit of evidence between the 7th edition and 8th edition of AJCC. This is a small research which we did I did with my undergraduate students, where we took from our archives, we took the slides and saw, and we did the depth of invasion, as well as we tried to see whether there is an upstaging for the T as well as we also reported the upstaging for N. And you can see that the overall survival doesn't make much difference between the 7th edition and 8th edition here. This could be because of our sample size, which was very small. It's about 75 cases only. And but however, for the nodal status, when we saw between the 7th and 8th edition, the survival for of these patients with an upstage nodal status was very low, and it was significant. And the risk hazard ratio was about 5 folds. So this is what we got. Let's see another evidence for the AJCC 7th. Between 7th and 8th edition. This is an external validation which they have done on about 300, near to 300 cases, where they said that upstaging of PT showed worse disease-free survival and overall survival, and upstaging of PN also showed worse disease-free survival and overall survival. Okay, going on to the microenvironment. I'm just going to touch a little bit of this microenvironment. I'm not going into deep because there's a lot of other things which can be done in terms of microenvironment. I will only talk about the lymphocytic host response. This is a strong lymphocytic host response where you can see a band of lymphocytes around the tumor at the invasive front. So if you see such a band of lymphocytes around the tumor uniformly throughout the tumor, then you put it as strong lymphocytic host response. If you see some places which are strong and some places where the lymphocytes are not present, okay, then it is an intermediate lymphocytic host response. And these are the strong areas. You can see the black arrows, whereas these are the intermediate areas, the white arrows, where you don't see much of lymphocytic host response. And here you hardly see any lymphocytic host response, not much of lymphocytic host response is seen, and this is a weak lymphocytic host response. And there have papers which have been published which says that depending on the lymphocytic host response, the prognosis varies, especially for the strong and the intermediate, strong, it is good prognosis, whereas intermediate and weak, there is a poor prognosis. We have an unpublished paper on this, where also we found that the intermediate and weak lymphocytic host response had a poorer overall survival than the strong lymphocytic host response. Okay, so these are the information that you're going to go put it in the crystal ball, and which comes as a report to the oral surgeon, and that is going to help him a lot to see what next he needs to plan for his patients. If his margin status is positive, it is as good as telling that the survival rate, the recurrence, and the metastasis is poor. If the margin status is negative, then it is good. But you have to look into other criteria as such. The depth of invasion. If the surgeons do take into consideration a 4 mm cutoff as the depth of invasion, there is a debate between whether you need to take into consideration 4 mm or 5 mm, but the AJCC 8th edition has given us as a guidance of 5 mm as such. So the greater the depth of invasion, the survival is going to be poor, there could be the locoregional recurrence is going to be higher. And when it comes to perineural invasion, again the survival is going to be affected. If there is presence of perineural invasion, the survival is going to be affected. The locoregional recurrence is also going to be present, and the metastasis can happen. If it is lymphovascular invasion, then it's going to be more of your lymph node metastasis which might happen. So these are the clues or the information that we can actually put it in this crystal ball and give to the surgeon to actually make sense of what he's going to do for this patient or not. And if it is a definite margins positive, then he definitely needs to send the patient for shining. He has to send the patient for adjuvant radiotherapy. If there is positive margin and perineural invasion, definitely he's going to again send the patient for radiotherapy. Sometimes they might think about adjuvant radio and with chemotherapy. CCRT they might be thinking of. So if we are giving all these information to the surgeon, he's going to be happy. He knows what next to do for this patient. He can communicate with the oncologist and give the best treatment for the patient. That is the ultimate aim of what our report is going to do for the patient, the surgeon, and the oncologist. Okay. With that, I come to the end of my presentation. Here, I would like to thank these are my lab technicians, without whom I wouldn't have got those lovely H&E sections. I would like to thank them all, and this is my department. I'd like to thank all my colleagues as well as my postgraduate students with whom I've learned from them a lot. And I'd like to also thank my head, Associate Professor Dr. Zureza, as well as Prof. Tilak, with whom I'm working closely now on oral cancer. And thanks to all the surgeons from the Faculty of Dentistry, University of Malaya, and a special thanks to Dr. Saravanan Gopalan, who has given me a lot of inputs too. And I would like to thank these two grants from which these images have been taken. And thank you. And this is my contact detail. If anyone wants to collaborate with me for any research, you can feel free to contact me. Thank you very much. Hopefully, I have not taken up time over than what I was given.
Thank you, sir. That was a fantastic session on one of the most important topics in medicine. It was very enlightening, giving new dimensions to the reporting of cancers that we usually do. We do have some questions from the audience. I'm sure I can vouch that they immensely enjoyed it, which is evident from the number of questions that we have. So can we proceed with the question and answer session, sir?
Yes, please. I'll try my best to answer.
Yes, sir. So you spoke about microinvasions, sir. So are there any guidelines to assess the microinvasions, sir?
Okay, anything, if the tumor emboli is about in the node, if it is less than 2 millimeters, then it is called microinvasion. If it is more than 2 millimeters, it is called conventional metastasis. So that is the criteria. It's 2 millimeters or less is microinvasion. The tumor metastasis, the tumor should be. So let me just share this. Share again, sorry. So here you can see the tumor is around this large, isn't it? It's going. So what I will do is I'll measure the greatest dimension of the tumor. So if the greatest dimension of the tumor is more than 2 millimeters, then in the lymph node, then that's a conventional one. So if not, if it is around less than 2 millimeters, then it is called as micrometastasis.
Okay, so what about the microinvasion, sir? That is just below the epithelium in the primary tumor. Microinvasion,
okay.
sir.
Microinvasion.
Yes, sir.
Fine. Sorry, let's go to the, okay. It's just subepithelial.
Okay, sir.
Okay, that is my microinvasion. Superficial invasion, you are looking at the retipex, okay, and you have the lamina propria. If it is into the lamina propria, then it is superficial invasion. So that is the difference between microinvasion and superficial invasion. Microinvasion is just below the, you have a small breach in the basement membrane, and the tumor cells are just subepithelial to the epithelium. So that is microinvasion.
So is it associated with additional findings like increased vascularity in the superficial connective tissue? Are there any additional factors which correlate with that, sir, which can take us towards a path of invasion?
Okay, it's I'm not sure about that, but what I feel these microinvasion is usually is you can see them in small biopsy specimens, okay, where you can see the microinvasion, but that might be another place where there is frank invasion as such.
Okay, sir.
But then if the tumor is very small at the initial stage T1, you can have, you're going to look into microinvasion, and usually those which are highly dysplastic, and you are thinking about it's going to be mostly oral potentially malignant disorders, but you think about oral potentially malignant disorder when you're biopsying, but then it turns out to be microinvasive squamous cell carcinoma.
Okay, sir. Thanks a lot, sir. Sir, is it something similar to carcinoma in situ, sir? Which is it okay to use this term anymore, sir? Carcinoma in situ while reporting cancers.
Okay, so I have not touched on epithelial dysplasias. You have the two, the last WHO book which did talk about the binary terms of using epithelial dysplasia, the high grade and the low grade, where they said the severe dysplasia and carcinoma in situ as high grade, and the mild dysplasia as low grade, and they have still having a lot of issues with where to put the moderate epithelial dysplasia. So that needs a lot of research as such. The three-tier system of mild, moderate, and severe and carcinoma in situ for me is the same.
Okay.
They both behave the same. Whereas the mild and moderate, you can go for the three-tier, but the latest WHO, it's better at present to actually do the three-tier and the two-tiers and see where your moderate epithelial dysplasias actually fit into the two-tier, whether they are going into high risk or low risk.
Okay, sir. Thank you, sir.
That needs a little bit of research there.
Okay, thank you, sir. Sir, are there any diagnostic aids for field cancerization, sir? Can you add a note on that, sir?
Okay, I have some experience on adjunct diagnostic tools. I have worked a lot with Wellscope, which is an adjunct diagnostics tools. There are quite a lot in the market. There are quite different ones, but a systematic review by Saman Varnakulasuriya did say that cytopathology is one of the best adjunct diagnostic tools than the others. And if you combine the glacial acetic acid and the fluorescence technique, that also gives a better one. So that is what I can offhand think about. But there are different techniques, and there's also this DNA ploidy, which is a big controversy because of certain papers, a lot of papers which were retracted. But then that is also is one of very good, and I think Professor Eddie Odell is doing a lot in the DNA ploidy side. So these are the adjunct diagnostic tools. At present, we can't say that which is better and which is not. Still, a lot of research needs to go into that. And at present, from the meta-analysis of Varnakulasuriya, they have given it as cytopathology being the best.
Okay, sir. If at all we are suspecting a field cancerization, sir, how to put it in our report, sir? How can we ask for additional biopsy, or what? I mean, how can we convey it to the surgeon, sir?
How are you going to report field cancerization from a slide?
If I'm going to suspect it, in case if there's a strong suspicion based on
you have an incisional biopsy, is it? Okay, and see that's where it's more of a clinical judgment than an histopathological judgment. I would go.
Okay, so
go with. If I communicate with this oral surgeon and he says that there are multiple areas, then I would say better do a multiple sampling and give me. That would be the best. I can see everything and then report to him.
Okay, sir.
So that's where your communication with the surgeon is very important.
Important. Thank you, sir. So the next question would be, can you add a note on role of artificial intelligence in OSCC staging, sir? Is there one? And if at all, how could that help us, sir?
Okay, people are doing quite a lot on that front as such, artificial intelligence, with retrospective data. But then huge data are required. That is what they are finding it difficult. And if you're talking about staging, then they are artificial intelligence actually using the CT scans and MRIs, which they have started. That is research in progress as such.
Okay, so so as a concluding question, we do have many more questions, but because of time constraint, what we can do is we can send them to you, sir, and you can reply them back when you're in leisure, sir.
Sure.
And as a concluding question, if I have to give a report, a pathology report with all the features mentioned by you in the session, sir, what can I say beforehand? The surgeon is going to sit with me before doing the biopsy. What can I ask from him, sir? To give such a report, what are my requirements, sir, from the surgeon?
Okay. I'm not talking about the incisional biopsy here. I've been only talking about the surgical pathology after they have got the surgical specimen. The only dispute I will be having is on if the marking is not correct. They are going to send me with certain markings, and if I am in doubt, then I will definitely call the surgeon to my crossing center and ask him what the margins are if they are not properly done. I know the surgeons are very busy people, and usually what happens is the surgeon cuts, and then it's one of the trainees who are doing the marking and so on, and the surgeon instructs them. Sometimes there is a miscommunication there also. It could be there. But to reconfirm things, what I will do is I will call the surgeon if in doubt, and ask the surgeon on the crossing table where these margins are. The other one is if the surgeon actually has, let me show you this, the level of invasion, level of the lymph node. Okay. If the surgeon actually has this diagram and he pinned the specimens on this, it is very good. We can easily gross it and put it in and do the labeling. But if the surgeon has actually put it in bottles, then it is completely on the surgeon's this one that whatever he's telling, I have to take it. Okay, so he's put in 1A in one bottle, 1B in one bottle. I will have to take it as 1A and 1B as named. So I can't do anything of that. But if the surgeon has put in this, I'm going to be the one who's crossing. So I know exactly where the surgeon has placed the tissues, and I will know how to. If there is any doubt in this too, I will call the surgeon and ask them. Usually this doesn't happen if they put this diagram and pin the specimens.
It's 12 o'clock.
Thank you, sir. That was a great session, sir. Now over to Dr. Ramesh, professor in our department, to deliver the vote of thanks.
Good morning to all. Thank you for giving this opportunity. On behalf of the Department of Oral Pathology and Microbiology, I take this opportunity to thank our management, Chairman Sir, Dean Sir, and our Vice Principal Sir for providing their immense support in conducting this webinar. I extend my sincere thanks to our speaker, Dr. Anand Ramanathan, for having readily accepting the invitation to share his knowledge and enlightening us and helping us overcome many practical challenges that we face in reporting of oral cancer. Thank you, sir. I would like to thank all the participants who took part in the session and made it more interactive and lively with your questions. Thank you, one and all. I would like to thank our department head and vice principal, Dr. K. Rajkumar, sir, for being the driving force in rolling the webinar live. Thank you, sir. Finally, I would thank
our team of faculty for extending all technical support and making the program a fruitful one. Thank you all. Now I request our HOD sir to give the certificate of presentation to the guest speaker.
Thank you, sir. Thank you, Dr. Anand Ramanathan, for this excellent presentation. In fact, during the introduction, I was talking about the role of a pathologist, interaction with the surgeon, orientation of the specimen, and using certain terms like depth of invasion, extracapsular spread, margins, and things like that. Probably during that time, my colleagues would have been really confused with all these terms. I think you have very clearly explained all those things, comparing between your AJCC 7th edition and 8th edition. And most important thing is the way that you have broadened the perspective of an oral pathologist. Instead of merely reporting a cases as squamous cell carcinoma and at the maximum giving the histological staging, we have given a different perspective altogether. What role that an oral pathologist has got to work in conjunction with the oral surgeon by giving him details regarding the response, regarding the depth of the margins and all those things, which will play a very important role for the surgeon to plan the surgery, and not only to plan the surgery, to decide about the adjunct treatment as well. Thank you very much, sir. As a token of our appreciation, we hand over the certificate from the Department of Oral Pathology at SRM Dental College. Thank you very much, sir.
Thank you very much for the invitation, and I thoroughly enjoyed this webinar, making this webinar. Thank you very much, sir, for the invitation.
Thank you, Dr. Anand. And for the audience, the feedback form for the certificates is there in the chat box. Kindly fill up the feedback forms for the certificates to be generated. And in case if there is any issues with the certificate, you can mail us at the mail ID, which is already provided in the chat box as well, or the mail ID is there in the invitation which you received. So thank you one and all for being present here and gracing the occasion. And once again, I thank Dr. Anand for having readily accepted my invitation, and thanks for the wonderful session. So with this, I think we will end the session and have a great day.